Good morning, afternoon, evening, everyone. We know we have several guests that are joining us from all over. Welcome to Cancer Prevention and Early Detection for Community Health Centers. Our topic for today is going to be cervical cancer prevention and screening, pathways to greater access. My name is Gabrielle Darville Sanders. I currently serve as the Strategic Director for the ACS National HPV Vaccination Roundtable. And I have the pleasure today of serving as your moderator for this wonderful webinar that we're going to facilitate. As we get started today, we're going to launch a quick poll. But before we do, here's a quick agenda for the topics that we will explore. So the first speaker is Dr. Rebecca Landy. She will be joining us and speaking about why access matters, the public health landscape. Then we'll be joined by Dr. Temkin, who will go into deeper talking about cervical cancer screening and HPV self-collection guidelines. And then we'll round it up with Dr. Tom Hutch, who's going to provide an overview of a primary HPV testing, just intervention and program that they did in a mobile clinic. We'll have a few minutes at the very end to facilitate Q&A, so feel free to submit your questions as our presenters are presenting. And we look forward to having you guys join us in our exploration of why access matters. Yes, so today our presentation will be recorded. You'll be able to share it with those who are unable to attend and join us for today's event. So quickly, let's go ahead and get started for today. We're going to launch a quick poll. So the poll should have popped up in front of you. Please feel free to go ahead and answer the 5 quick questions that are available in front of you. And as you guys are doing that, I'm going to go ahead and introduce our first presenter. So our first presenter for today is Dr. Rebecca Landy. Dr. Landy is a principal scientist for the Cancer Risk Factors and Screening Research Team within the Surveillance Prevention and Health Services Research Department of the American Cancer Society. Her research focuses on cancer screening, prevention, and early detection of cancer across multiple cancer sites. She's interested in the evaluation of emerging screening technology. And, I'm sorry, her bio just went off screen. So Dr. Landy is available or interested in the evaluation of emerging screening technology and screening of eligibility criteria for targeted cancer screening programs such as lung cancer. Before joining ACS, she was a research fellow in the Clinical Epi Unit and the Division of Cancer Epidemiology and Genetics at NCI. Prior to that, she also was at Queen Mary University of London, focusing her research on cervical cancer screening and modeling the impact of HPV vaccination on cervical cancer incidence. Her research has informed national, international cervical and lung cancer screening guidelines. Let's go ahead and welcome Dr. Landy.
Hi, thank you very much. So I'm going to start us off just with an overview about cervical cancer incidence and mortality, HPV vaccination, and cervical screening. And before I get started, I just want to thank my colleagues Molly Black and Sarah Temkin for letting me use some of their slides in my presentation. So the most recent estimates predict that there will be approximately 13,500 cervical cancers diagnosed in 2026 in the US and around 4,200 deaths. And to tell us how common this is, we can also consider these numbers as rates, which tell us how many people per 100,000 individuals will be diagnosed with or die from cervical cancer. And the corresponding numbers here are 9.7 per 100,000 people will be diagnosed with cervical cancer, and 3 per 100,000 will die from cervical cancer. The World Health Organization has a cervical cancer elimination initiative, which is for all countries to reach and maintain an incidence rate of below 4 per 100,000. So given that the US incidence rate at the moment is around 9.7, we still have a way to go. The good news is that both cervical cancer incidence and cervical cancer mortality have decreased by over 50% since the 1970s. However, since almost all cervical cancer mortality is preventable, both through HPV vaccination and cervical screening, there's still more that we can do to reduce this further. Next slide, please. Although cervical cancer rates are low in many parts of the country, rates in some parts of the US, mostly in the South, still where the national average was in the 1980s, and twice as high in the states with the lowest incidence rates. Sorry, twice as high in the states with highest incidence rates compared to the lowest incidence rates. And even the states that have the lowest incidence rates don't meet the WHO goal of less than 4 per 100,000. And we see a similar pattern when we're looking at cancer mortality, with the highest rates in Oklahoma, Arkansas, Mississippi, and Alabama, where the mortality rate is around 3 times higher than in the states with the lowest cervical cancer mortality rates. As well as differences in cervical cancer incidence and mortality between states, we also see differences by race and ethnicity, with American Indian and Alaska Native individuals having an incidence rate 65% higher than white individuals, mortality rate 70% higher. Next, I'm going to talk about prevention and early detection. So what can we do to try and reduce both incidence and mortality? So I want to start by looking at the natural history of cervical cancer. So individuals can acquire a cervical HPV infection, and the majority of these infections will clear naturally without any intervention needed. However, a few will progress to CIN, which is cervical intraepithelial neoplasia, and that can progress through stages CIN 1, 2, and 3. Most CIN 1 will regress again by itself without needing any intervention. Some CIN 2 also will regress, but those that progress to CIN 3 can then also progress to cancer, and that's what we are trying to prevent. So we have 2 very effective interventions against cervical cancer. The first is HPV vaccination, which prevents the acquisition of the HPV infection. And the second is cervical screening, where we detect and treat abnormal cells to prevent progression to cancer. And I'm going to talk briefly about each of these interventions. So let's start with HPV vaccination. This has been approved in the US since 2006 and is currently recommended for everyone aged 9 to 26, with shared decision recommended for individuals aged 27 to 45. And in 2023, vaccination rates were kind of reasonable, so 65% for females and 61% for males aged 13 to 17 had received at least 1 dose before their 13th birthday. And in 2022, 52% of females and 31% of males aged 19 to 26 reported ever having received at least 1 dose. And vaccination is important because it's estimated to reduce the lifetime risk of cervical cancer by around 85% for individuals vaccinated by age 12. And in kind of good news that we can already start seeing the impact of vaccination, this year's Cancer Facts and Figures reported that the rate of cervical cancer in women aged 20 to 24 has decreased by around 11% a year since 2012. And another way of seeing the impact of vaccination is by looking at the rates of CIN among women who receive the HPV vaccine at young ages. So although changes in the rates of CIN can be seen much earlier than changes in cancer rates because it's much earlier on in the natural history, it's only detected among individuals who are screened. So it's not considered quite as strong evidence. However, we can see in this figure that among women aged 20 to 24 years who were screened for cervical cancer, rates between 2008 and 2022 decreased for SIM3 plus by 80%. And in the same period, SIM3 plus rates among screened women aged 25 to 29 years, where there was still some vaccination, but lower rates, so that all women were vaccinated at later ages, in the 3 plus rates decreased by 37%. As with cancer incidence, there's also wide variation in the proportion of individuals aged 13 to 17 who are up to date with HPV vaccination, which in this figure was defined to mean that they received at least 2 doses at least 5 months apart. So Dr. Temkin will talk more about cervical screening, but I just want to give a brief overview of why it works and show a couple of slides about screening uptake. So cervical screening is recommended for individuals aged 21 to 65 by the United States Preventive Services Task Force, or individuals aged 25 to 65 in the American Cancer Society guidelines. There are 2 tests that can be used for cervical screening: HPV testing, which aims to detect high-risk HPV infections, and cytology or pap testing, which detects abnormal cells. And the screening interval for HPV testing is 5 years compared to 3 years for cytology or pap testing. And that's because it's aiming to detect a state which is further back in time from when the cancer would develop. So you can afford to have a longer screening interval. The ACS guidelines were updated in December 2025 to include self-sampling, which Dr. Temkin will talk about more. And finally, just say that screening is a very important part of cervical cancer prevention, as attending screening regularly is estimated to reduce the risk of cancer by 70%. And in addition to reducing the risk of cancer, it can also lead to early detection of asymptomatic early stage cancers. So we can see in this figure that early detection is important. The 5-year relative survival is much higher for cancers diagnosed at a localized stage than for regional or distant cancers. So we can see here that the overall 5-year relative survival from cervical cancer is 67%. However, this is much higher for the 42% of people who were diagnosed with a localized cancer, 91% 5-year relative survival, compared to only 19% for the 15% of people who were diagnosed with a distant cancer. And this slide shows, sorry, next slide, please. Thank you. This slide shows trends in the proportion of people who are up to date with cervical cancer screening between 2000 and 2021 by race and ethnicity. Historically, cervical cancer screening rates have been lower in Hispanic and Asian women than white and Black women. And we see some kind of interesting differences between the prevalences of screening and what we might expect to see in cancer rates. Because despite Black women having among the highest screening rates, their cancer incidence was 18% higher than for white women in the figure that I showed earlier. And additionally, Asian individuals have the lowest screening rates, but they also have the lowest rates of cervical cancer. So individuals who are up to date with cervical screening, according to the USPSTF guidelines in 2021, that was 73% overall. But in addition to the differences that we see between race and ethnicities, there's also a lot of other differences. So for example, the proportion of women who are up to date with screening was only 56% for people with less than a high school education and 83% for college graduates. It was 63% for individuals below 100% federal poverty level, compared to 77% for people above the 200% federal poverty level. It was 55% among uninsured individuals, compared to 77% for individuals with private insurance. Okay, and then finally, I just wanted to show one slide showing data on cervical cancer screening trends at federally qualified health centers, where screening rates are below the national average, which in the US population overall was 73%. And this is far below, this current estimate of 55% is far below the Healthy People 2030 target of 79.2%, and even further below the 90% proposed screening target for the elimination of cervical cancer. Thank you, and I'll now pass the presentation over to Dr. Temkin.
Awesome. Thank you so much, Dr. Landy. Such a great presentation, and we look forward to the continued presentations to kind of round out our conversation around access. So I have the pleasure of welcoming Dr. Sarah Temkin. Dr. Temkin is the Senior Director of Early Detection at the American Cancer Society. Dr. Temkin is a gynecologic oncologist who earned her medical doctorate from Georgetown University, completed her residency in OB/GYN at Mount Sinai, and completed a fellowship in gynecologic oncology at the Sunny Downstate Medical Center. She worked as a clinician and scientist in academic medicine for over 2 decades, has been recognized for expertise in cancer prevention screening, clinical trials, women's health, and health equity. Prior to joining the American Cancer Society, Dr. Temkin served as a clinical expert with the Division of Cancer Prevention in the NCI and as an associate director for clinical research within the Office of Research on Women's Health at National Institutes of Health. In her work at the National Institutes of Health, she coordinated research on women's health across the agencies, institutes, centers, and offices, and provided clinical expertise on matters related to gynecologic cancer and cancer care for women. Let's go ahead and welcome Dr. Temkin.
Thank you so much for having me and for that what felt like a long introduction. It's more bio, but I am so happy to be here today to talk a little bit about cervical cancer screening. If you could go to the next slide, there's one between there. Yeah. So cervical cancer, as we heard a little bit about, is really sort of an ideal setting to use screen screening for cancer prevention. The nearly all cases of cervical cancer are caused by the HPV virus, which is extremely common. Although most infections will clear over time, for those women who go on to develop premalignant or malignant lesions of the cervix, there is a long latency period, which allows screening to detect lesions before they become malignant, allowing for prevention. The next slide. We also heard so nicely from Dr. Landy about how there is still 13,000 over 13,000 cases of cervical cancer in the United States every year and 4,000 deaths. And although these numbers have declined significantly over the last 50 years, if you look at the right side of this graph, you can see that the mortality incidence numbers have declined very minimally over the last 2 decades, despite widespread availability of screening for over 50 years and vaccine that's been approved for nearly 2 decades. The next slide. We see this as well in when we look at diagnoses of cervical cancers across the United States, and underscreening remains a significant contributor to this issue. Over half of women who are diagnosed with cervical cancer in the United States have not had a lifetime screen, and despite the availability of both primary and secondary prevention, most cervical cancers diagnosed in the United States are diagnosed at a late stage. Next slide. I'm going to show this slide from Dr. Landy, just showing that although 3/4 of United States women are up to date with cervical cancer screening, this number falls short of what our public health agencies recommend. And also there are variations by race and ethnicity, although these are not large enough to account for the differences that we see in cancer outcomes. The next slide. And there are, of course, multiple barriers to screening um, and receipt of screening that include individual and community factors such as fear or stigma, as well as systems and structural factors that include things like scheduling, availability of transportation, and costs that are associated with healthcare. You can go to the next slide. When we look at screening rates a little bit more carefully, we can see that there are various social factors that influence access to screening. And we see pretty clearly that multiple vulnerabilities in social status can overlap to result in some of these disparities that we see. Women who are born in the United States, privately insured, living above the poverty level, or with a college degree are all more likely to be up to date on screening, whereas women without these things are less likely to be up to date on screening. The next slide. We also see how these multiple individual and structural factors can influence screening rates across various geographic settings, as shown by states in these two maps. Amongst statewide populations, rates vary, up-to-date screening rates vary between 69 and 83%. But in safety net settings, which is shown in the green map on the left, you can see that screening rates are overall lower, and they're consistently lower than the statewide average. if you could go to the next slide. I also want to emphasize that cancer screening is not simply the initial test or the HPV test or the cytology test, but that screening is a process. And across that process, there are multiple additional opportunities for people to be lost from the screening continuum. There are places where people need to receive results. You need to be aware of an abnormal result for a screening test to be useful. And this may not happen for a lot of people who, for a lot of different reasons, including being on the wrong side of the digital divide. There are also follow-up appointments to schedule, considerations of transportation, co-pays, and all of those things. And we also know that once a cancer diagnosis is made, many of these barriers persist for a lot of people. The next slide. When we think about screening as a process for cervical cancer, we see that there are many opportunities for improvement. Over half of the patients who are eligible for screening, we already said 3/4 of them are up to date. Over half of those patients who have an abnormal screen do not get timely follow-up, or defined in this study as follow-up within 3 months. The median time from biopsy to treatment in another study that's shown here was over 2 months. And all of these delays reflect issues related to healthcare access and impede improvements that could be achieved through screening in cancer outcomes. The next slide. So I think a lot of people are very hopeful, and I hope that I make you all, everyone in the audience, hopeful today too, that self-collection provides an opportunity to improve early detection. The next slide. The American Cancer Society updated its guidance on cervical cancer screening in December of 2025 to include self-collection as an option for those people eligible for cervical cancer screening. And I'll also just mention that the new guidelines clarified the exit to screening, that it's not simply turning 65, but it's a combination of age and previous cervical cancer screening history. The next slide. And there's a click in here too, if you want to do one more. Yeah. This is just to mention also in December of last year that HRSA also released new guidance, which can be used for coverage, for insurance coverage, stating that patient-collected HPV testing is an appropriate method for cervical cancer screening and is an option for patients aged 30 to 65. And I just want to mention that the ages in this recommendation are slightly different than the American Cancer Society ages. The next slide. There are several available self-collection kits in healthcare settings. The self-collection of HPV was approved by the FDA in May of 2024. And last year in May in 2025, a device for home collection was also approved by the FDA. The next slide. Self-collection is easy to do. I think we all became very familiar with how to use a swab to collect a specimen during the COVID pandemic. And this is very, very similar. You wash your hands, use a swab, insert it into the vagina, and then off it goes to the lab. The next slide. And a question that everybody should be asking is this accurate? And the accuracy of this test certainly was considered in having the American Cancer Society update its guidance. There have been three large meta-analyses that have all evaluated the test performance of HPV when it's self-collected. All the conclusions of this is that self-collected HPV is more sensitive than cytology or a traditional pap smear. When used alone and has comparable sensitivity and high agreement with a clinician collected HPV specimen, which would be the other standard. The next slide. So if you want to think about who is eligible for self-collected HPV testing, it really technically is anyone who is eligible for primary HPV testing. There are certain criteria which but to evaluate patients who are at higher risk for cervical cancer or dysplasia, which we think should still have a clinician collected screening test. And I think it's important to be mindful of the fact that patients with HIV or other immunosuppression, people with a history of DES exposure are still at higher risk for disease, and to consider directing these patients towards clinician collected testing. Also, because of insurance coverage issues, those patients who are under age 30 or have Medicare as their primary coverage may not be eligible for insurance coverage of their primary HPV testing if it's self-collected. The next slide. So, another question I think that people have about this is, are patients going to do it? And I think it's been pretty clear from the literature that patients find this to be highly acceptable. By this, I mean vaginal specimen collection across multiple settings. Patients report it as being easy to perform, relatively painless, and it affords a degree of privacy that you don't have during a clinician-collected examination. The harm that I want to mention is that there is a potential to miss a physical exam finding, whether it's a polyp or a lesion or an infection, and that, goes to one of the considerations that needs to be made. The next slide. Because patients who have symptoms are still going to need a clinical evaluation. So the historic, typical textbook symptoms of cervical cancer include postcoital bleeding or other abnormal bleeding, hematuria, dyspareunia, or other pelvic pain. And so whether or not these patients have a self-collected HPV test for cervical cancer screening, they still certainly need a clinical evaluation of symptoms. The next slide. I think one of the greatest opportunities of self-collection is it changes the setting in which cervical cancer screening can be performed. And maybe I'll add comfortably to this. Before self-collection, cervical cancer screening required a healthcare professional who was comfortable and trained to do a pelvic examination. It required specialized office equipment that includes a table with stirrups, and often in many healthcare systems requires a standalone setting, a standalone appointment. But after self-collection, this really can be ordered by any healthcare professional because the patient does it themselves, and can be included in any other screening appointment, a lab visit, radiology visit, or other setting, as long as the patient is afforded an area with privacy. The next slide. And so I think this is my last slide, and sort of the last point that I wanted to make was around going back to screening as a process, because self-collection, if it's instituted within a system, does change the screening process. There will be an increase in abnormal screens found because the self-collected HPV specimen cannot be sent for reflex cytology, which means that there will be more positive HPV tests that don't come along with normal cytology or even ASCUS cytology. And so within systems, there needs to be some mindfulness and intention around changing referral systems so that the increase in abnormal screen positive tests can be evaluated, and colposcopy needs to be available, and then treatment for those patients who are found to have high-grade dysplasia. Because that's the way that we're really going to move the needle and improve cancer outcomes from this disease site. And with that, I think I will end and wait for questions and turn the microphone over.
Thank you, Dr. Temkin. Such an engaging and enlightening presentation. I know there's going to be a slew of questions that come in, and so we're excited to facilitate that, talking about self-collection. So I have the pleasure of introducing our last but maybe our best, we'll see. Presenter for today's webinar, Tom Hutch. Dr. Hutch is the medical director of We Care Daily Clinics, an organization of opioid treatment programs serving the Washington communities of Seattle, Auburn, and Tacoma. He completed his medical training in family medicine at Swedish Medical Center, First Hill in Seattle, where he taught residents as a faculty physician before working to address systemic causes of behavioral health disorders and addiction in community health centers, and as a county jail physician with public health, Seattle and King County. Dr. Hutch is a clinical assistant professor in the University of Washington Department of Family Medicine and provides instruction to addiction medicine fellows. He also works with the Washington Healthcare Authority to expand hepatitis C treatment access and serves as the medical director of the Indigenous Pact, which assists Native American tribes in establishing clinics to address substance use disorders. Go ahead and help me welcome Dr. Hutch.
Thank you so much, and thanks for inviting me to speak. I'm lucky to be able to offer this program to our patients and excited to share it with you. HPV Self-Collect has promised to increase cervical cancer screening rates in this high-risk community health center population. I hope our small example can instill some confidence that this is both critical to offer and that almost any setting can make this work. I don't have anything interesting to disclose. Speaking of funding, though, I do want to acknowledge our support. We have had a lot of this work be made possible by the Fred Hutch University of Washington Seattle Children's Cancer Consortium, and also, of course, Liz Swisher's lab at the University of Washington, who has offered us lots of support. I do mention some grant funding, but to be clear, funding shouldn't be a barrier for offering this. This is a billable service. It's very simple to process. And next slide, please. So while our project setting is unique, as someone who's worked in FQHCs, I'll say that there are many shared characteristics in our patient population and facility resources that hopefully make our work and its outcomes here in my clinic broadly applicable to many underscreened populations in clinical settings, and that, as Dr. Temkin highlighted, there are very few facility requirements beyond a private area to make the work possible. So opioid treatment programs are ideal settings, I think, to provide cervical cancer screening to a marginalized population. We serve individuals for whom perceived stigma has often generated avoidance of healthcare interactions, leading to low receipt of primary care, including vaccinations. We see people who have not had screening or primary care for years due to active substance use for years, having just been released from incarceration or lack of access. OTPs provide safe spaces and trusted medical relationships for our clients. And though staffing and resources vary, OTPs have the experience of having medical providers equipped with collecting specimens. And in Washington, we're required to offer screening for hepatitis B and C and HIV and syphilis. So our staff is set up to at least process and counsel people about sample collection. A little about our organization specifically. Next slide is that we're located in Seattle. We serve about 1,800 clients in the area who have access to medical services through us, including management with medication for their substance use disorders, as well as testing and treatment of other conditions like hepatitis C, HIV, and other STIs. Each client also has access to counseling services with on-site substance use disorder professionals and certified peer support specialists. People come to the clinic frequently to receive medical and counseling services as well as medication. The frequency ranges from daily to a visit once monthly to get medication and services. We also operate 4 mobile units. These are essentially clinics on wheels equipped with a medication dispensary, medical exam area, and restroom facilities. And we serve around 200 clients in the Tacoma and Seattle communities with that model. Next slide, please. While we do some procedures such as Nexplanon, important to highlight for the applicability of what we're doing and why it might work in your setting, we don't have facilities for gynecologic services or exams. And here's a little bit of a breakdown about our demographics. Next slide, please. So our project goals here are to introduce and evaluate a low barrier model for integrating HPV self-collect for cervical cancer screening into our OTP. We wanted to measure the current rates of screening and also the testing outcomes, which is to say high-risk HPV positivity rates. We also wanted to assess its acceptability to clients. How often are people who otherwise do meet screening guidelines accepting it and taking us up on the offer? And when they don't, what are the barriers? And of course, facilitating referral and follow-up. Next slide, please. So our project workflows, we're essentially, this is guideline care. I don't think that a lot of this strays from what you see in guideline recommendations. We did elect to offer HPV screening at people's annual medical update visits. So that's after they've been with us for a year. There's a lot of times that you could offer this in clinic. However, we started with our people getting an annual medical update because after it's been a year, it's highly likely that people will still be retained in our care for long enough that we'll have time to provide the result from the HPV test to them and have time to help them with follow-up, given that retention rates after a month for opioid use disorder treatment across the US are generally low. So this was hopefully a really low barrier workflow. People are coming in and they're using the restroom anyway when they're being roomed for their annual medical update. So we would say something like, since you're already going into the restroom, and the MA would have a script, and you can see it there on the left, we're offering cervical cancer screening to eligible individuals with the self-swab that they would administer themselves in the bathroom. Do you have a cervix? And, we'll go through their screening history and see whether they qualify. And on the next slide, you'll see briefly decision tree, which Dr. Temkin noted is different with some considerations of previous testing for those over 65, as well as a HPV vaccination questionnaire for us to get some data on how often people are getting vaccinated. Next slide, please. People were offered a kit for self-collection. This is what it looks like. Also, like it was previously discussed, I think a lot of us are much more familiar with swabs after COVID. Maybe one more silver lining. People are, maybe that's a little more approachable to people now. Instructions were in English and Spanish with a diagram of the technique as well. It was completed in our facility restroom, either here at our brick and mortar clinic or on the mobile unit. So while parts of this are highlighting our mobile unit because it's an extra low resource setting, and hopefully that inspires everybody to take a look at the resources you're using and realize that if we could make it work in a mobile unit, that it could happen in the clinic. But we did offer this in the clinic as well. Those that were eligible but uncertain about proceeding were just encouraged by the medical assistant to discuss further with their medical provider at that day's visit. We gave them written info on HPV testing and cervical cancer screening from the CDC as well, in case they wanted some other reading material or had any questions. Next slide. HPV tests specifically, we talked earlier about some that are approved. These were sent to the University of Washington Molecular Diagnostics Laboratory in weekly batches. You'll note there that in June of 2024 is when we started, and that was before, that test at the University of Washington was approved. But you see the FDA approval later of some self-collect tests. So we actually switched at that point to LabCorp just because LabCorp was already integrated with our electronic health record, and it was a little easier to send the tests out and to receive them electronically in terms of the results. But both used the Roche Cobas, which was one of the three um, on-site collect swab systems that was mentioned earlier in the talk. Next slide. Negative results were given to patients via personalized letters. Positive results prompted an in-person medical consultation with lots of different outreach efforts for missed appointments, and people would sit with their medical provider here and discuss what the results meant and what the next steps were. We would follow guidelines for referrals for those testing positive for HPV 16 or 18 going directly to colposcopy, and those with other high-risk types being referred for cytology. Navigation systems using EHR reminders as well were utilized. People that we weren't able to get a hold of, we would continue to provide outreach, including through our peer support system. And those who we did meet with, we would set reminders at 1 and 4 weeks after the referral to verify the appointment was scheduled and see if we could help if they needed help calling and making one. Next slide. Those So you can make the argument that now the easy part is over and we have to help people get linked to care among a population that historically has had challenges being linked to care for a variety of reasons. So those with SUD report high rates of sexual abuse history, which can make follow-up testing traumatic. In addition, few people have their own transportation. There's a whole host of potential barriers, but we identified a list of trauma-informed gynecologic care providers in a variety of locations in the area. We sent referrals detailing the HPV results, talking a bit about our program, a referral letter explaining what we would like, and a request for follow-up testing. Some of the referral providers needed to do an established care visit first, which is understandable, but we selected a few key community partners that were able to just take a look at our letter. They understood what was going on, and they saw somebody for a PAP or a COLPO right away, which was fantastic. To address logistical and psychosocial hurdles, our clinic also offered free patient transportation to referral partners. And we also happen to have certified peer support specialists who themselves are in recovery from a substance use disorder and can help navigate and support our patients who come to us through a whole variety of things, whether it's housing applications or their own journey in getting to recovery. And so they were in a great position to accompany people to off-site gynecologic appointments for emotional support if that was one of their barriers. Next slide, please. In terms of health equity too, we've talked about that, and it was covered better than I could do earlier in this talk, but just another plug that bringing screening to patients in an area where they already feel safe and respected can help bypass structural barriers that lead to the mortality disparities that we see. Next slide, please. So hopefully my conclusion is that you can do this, but hopefully yours is too. You know, our we're still working on publishing the results of this ongoing project, but only 10% of people were up to date with their screening. 90% of people offered screening who qualified accepted, and high risk HPV positivity rates were nearly double the rate seen in the general screening population. So we frequently hear that patients with substance use disorders are hard to reach or non-compliant with preventive care, but our data suggests the opposite. When we removed the structural barriers, the exams, the appointments, the stigma, and simply offered a private, self-collected option in a place they already trust, 90% of people accepted. We found that only 10% were up to date. not because they didn't care about their health, but because the traditional system wasn't built for them and wasn't supporting their needs. So this model works because it restores agency to our clients. It moves us from talking about health equity to operationalizing it, making it happen. So if we can do this in a mobile unit in a parking lot, then I think we can and should do it anywhere. People are ready to engage. The tools are FDA approved, and I think now it's up to us to bring this life-saving care directly to people. Thank you. Thanks. I want to acknowledge the great people, by the way, at the Swisher Lab and our WeCare staff that made this happen, including our fantastic MA team and the diagnostics laboratory at UW that helped us with this as well.
Awesome. Thank you so much, Dr. Hutch. Great speaking voice, by the way. It's just like a calm cadence to the presentation.
Thank you.
Um, so I'm going to go ahead and invite all of my panelists back. Such an engaging webinar today. We opened up to talk about the data landscape, where we are concerning cervical cancer screening, our cancer rates, and then we transition into talking about self-collection and how we can improve access, and ended up with Tom highlighting a pretty much like a case study of a working day-to-day integration of how we can integrate self-collection into our daily work. And so I am so excited to facilitate this Q&A section of our webinar. Please continue to submit your questions. I know Dr. Temkin and our other presenters are answering some of these questions in the Q&A chat. So if we don't get the time to address all of them live, you at least have the opportunity to get some response via the Q&A section. I do want to first go ahead and ask Dr. Landy, you gave us a great overview of where we are with the data, right? And thinking about ACS, we just published our cancer facts and figures. From our cancer facts and figures, we are seeing that survivorship is longer. People are surviving, they're when they are diagnosed with cancer. And thinking about the integration of cervical cancer screening and HPV vaccination, where do you think we have to go? Like, how do we make sure? I mean, not just from a survivorship perspective, but how do we make sure that we're not adding to the number of cervical cancer screening, right? I mean, cervical cancer rates in the US. We know that our rates are going down. We want them to continue down. So how do we make sure that we're continuing to do the work to decrease the overall rates in the US?
So I think developments such as self-sampling for HPV
Mhm.
to that's going to hopefully encourage a different group of people who don't currently participate in cervical screening to be screened, which with appropriate follow-up can then reduce their risk of developing cancer.
Mhm.
For the younger people, HPV vaccination is clearly also has a huge role in preventing future cancers. So
Awesome.
I'd say it's implementation work. It's a big area now for how do we actually get people to be vaccinated and attend screening.
Awesome. Thank you so much. I'm going to shift questions a little bit, and we had a slew of questions wanting to make sure I don't ask the question that Dr. Temkin has already answered. So, one of the question is the self-collected swab option is only for HPV detection, correct? Not for non-HPV caused cervical cancer screening. There's still no self-collection option. Is that correct? I think it's for Dr. Temkin.
Yeah, so that is one of the limitations of self-collection, and that is also the reason that there will be more abnormal results with self-collected specimens instead of a clinician-collected specimen. There's not a reliable way to self-collect cytology. Um, this is a vaginal swab. It's not a it is not, although cervical cells may be shed are constantly being shed into the vagina. There's not a direct sampling of the cervix or the endocervix to make cytology possible at this particular moment technologically. And so to make it as accurate as it would need to be. So yeah, self-collection is just the HPV test. And I think that's one of the reasons for the under 30 and the Medicare covered patient that this is an issue because payment guidance is different than the American Cancer Society recommendations in those two age groups.
Okay. And so that was going to be my follow-up question. What is the cost of screening? Is it insurance covered? Is it self-pay? How does that work concerning the coverage to date?
Yeah, so the HPV, self-collected HPV use it's the same codes as where was used before for cervical cancer screening. And so for everyone in that 30 to 65 age range, there should be really no difference in the insurance coverage. The real difference is, as I mentioned, is those patients who may be under 30 or over 65, and then I'm not going to comment on every single case because there's an incredible variation in what gets covered across settings um, and insurances. But it should technically be covered exactly the same as a clinician covered test for those people aged 30 to 65.
Okay. And from the collection process, the question is it a vaginal or a cervical specimen? Like we can see the picture and we see kind of how you do the swab. It's kind of like when we did the COVID testing, how far up
Yeah.
the nostril do you go? Um, how far up do we go to collect the specimen? Is that too crass
You're
to
really
ask?
putting me on the spot
I'm
here, Gabby.
sorry.
The, um, the I, yeah, I don't even know how to answer that. It should not
Okay.
hurt. It should be less painful than doing a COVID test in your nose.
Okay.
I'll say it that way.
Okay. Okay, thank you. I'm going to shift some questions to Dr. Hutch. It sounds like a lot of people are very inspired by the use of the mobile van to provide care and the integration of self-collection as part of your protocol and the work that you guys are doing. Uh, Related, not related, do you have a restroom in your mobile van? Because especially if I assume that some of them may be doing it on site while they're in the van. So do you have a restroom, or do you park the van close to a proxy site where there may be a restroom available for the actual collection?
Great question. Both. We have a restroom on each of our four mobile units, as well as, of course, multiple restrooms here. It is the restroom that they are going to anyway, even on the mobile units, prior to their annual medical update visit in order to provide a urine sample. And so they're going in there anyway. I think that, even if it weren't paired with, hey, you're going into the restroom anyway, I think that going into the restroom, if you have that as a feature of your facility or mobile unit, is a great way to do it. But like Dr. Temkin highlighted, I think what you mentioned is just any private area, and I would agree. A restroom might be more comfortable, but I don't think that should be a barrier.
Okay. Um, same line of questioning for you, Dr. Hutch. If a client tested positive, did you have the client complete a traditional PAP before referring to for COPO?
We would follow the guidelines that it depends on the type, and if it was high risk 16 or 18 positive specifically, they would go to a colpo, and non 16 and non 18 high risk HPV would go to a cytology.
Okay.
I'm just going to take the opportunity since we're talking about this to just mention that because there were a couple questions also about if you have a history
Mhm.
of abnormal screening, or a pre-malignant lesion, like I just want to emphasize that there are situations for people like everything we've talked about today is for people at average risk of cervical cancer. So if you have questions about if you're at average risk or not, then it makes sense to talk to your clinical care team. Um, because for those people who are not, there are certainly different circumstances. There are people who should be having yearly exams. There are people who should be having clinician collected examinations. And so what we're talking about today is people at average risk.
Okay. Thank you. And I see Tom is answering some questions and Dr. Temkin is answering some questions. Apologies if you see me pinging to multiple screens. I'm trying to make sure we get them. Last question for today for Dr. Landy. We had a question and a comment about FQHCs in our state using the breast and cervical cancer early detection program to cover costs of cervical cancer screenings, and that it requires that you use the SPSTF recommendations for screening, which begins at age 21, and primary screenings not until age 30. So do you want to address or talk more about that?
Sure. Um, so the USPSTF guidelines are to start screening at 21, but using cytology until age 30, and then HPV testing or cytology from age 30. And this is because in the figure that Dr. Temkin showed earlier, HPV prevalence is pretty high at younger ages, so below age 30, but the risk of actually having abnormal cells is very low. So it's basically trying to protect against finding a lot of HPV with nothing clinically actionable at that time point. So you would just be following those people up. Whereas if you find someone with abnormal cells, that's what you would want to kind of act upon. So below age 30, the recommendation is cytology. And then once the HPV prevalence gets a bit lower and people are more likely to have abnormal cells along with the HPV, that's when HPV testing becomes more helpful.
Awesome. Thank you, Dr. Landy. Thank you, Dr. Hutch, and thank you, Dr. Temkin. We're going to end our Q&A for today. If you have any more questions, please feel free to drop them in the Q&A. Our presenters are answering them live as best as they can. We're going to do a quick poll and then just kind of wrap up with some terrific resources that would benefit for you guys. So the poll question should be coming up right now. And as you guys are answering the poll questions, I'll just kind of highlight some quick resources that you may find beneficial to your work in preventing cervical cancer, improving access. There is some new cancer screening resources from the American Cancer Society for both healthcare professionals and for patients. So feel free to access them via our website by scanning the QR code or just Googling and find them or selecting the link that has been dropped into the chat. Next slide. We also have some other screening resources that are available at ACS. Some of them are from our Cervical Cancer Roundtable, which includes a guide for implementing HPV self-collection for cervical cancer screening. We also have resources around coding and billing and insurance coverage. We also included our ACS Cancer Risk 360 tool, which is a great tool to determine your own individual risk. Our cancer screening disparity atlas, updated guidelines, and a slew of other resources that are available. So feel free to check us out and download the resource that's going to help support you guys in your work. And we also have launching next month our Best and Promising Practices series. This is a joint effort with the American Cancer Society and the HPV Roundtable. The series has been expanded beyond our 4 sessions. This year, we're having 6 sessions, and topics will talk about vaccine safety and impact, some QI success stories, partnering for vaccination progress, provider education for on-time vaccination, who are our champions for HPV vaccination, and cervical cancer elimination. So I encourage that you register to join us for this wonderful session throughout 2026. Next slide. And then we also have our rural learning community. This is our 3rd year of hosting our rural learning community. If you've participated, it's phenomenal, and we're revamping it again for 2026. We're adding more topics that have been identified here. We meet every 2nd Wednesday of the month between 2 and 3 Eastern Standard Time over Zoom, and come and join our champions or providers who are really passionate about improving rural HPV vaccination and cancer prevention throughout the United States. So we hope that you're able to join us and learn from your peers and collaborate and sharing resources with us and those who attend. Next slide. So we want to acknowledge the roundtables, the National HPV Vaccination Roundtable and the National Roundtable on Cervical Cancer, who are partners for this event. And we want to acknowledge our funder, the Center for Disease Control, in the award of the program that has put on this event for today. Next slide. On behalf of the American Cancer Society, our panelists, and all of the staff, as well as yourselves, want to thank you guys for taking the time to join us today to learn more about how we can improve access, overviewing the landscape of where we are, and being inspired to create the change through some innovative approaches such as a mobile health clinic, We hope that we can continue to support you guys in your work. Feel free to reach out, and our recording and slides will be accessible next week, so be on the lookout. Thank you again for joining us, and have a great remainder of your day.